also the medical director for the Pediatric Home Nutrition Support Program and the co-lead for the PEAS project. So May is Pediatric Feeding Disorders Month. This is a new diagnostic term, and we encourage you to use it to help raise awareness, support families, empower professionals, and advance the system of care for children with pediatric feeding disorder. And in particular, for those of you who are using Connect Care, to use the new diagnostic code that is now available. So that's very exciting. So we begin by acknowledging that our work is conducted on the territories of Treaty 6, 7 and 8 and the homeland of the Métis. We acknowledge that many Indigenous communities have been forged in urban centres across Alberta. We respect the treaties that were made with these territories, acknowledge the harms and mistakes of the past, and we dedicate ourselves to moving forward in partnership with our Indigenous communities. Okay, so a couple of housekeeping items. If you have comments during the presentations, you're welcome to put them in the chat box and select all panelists and attendees if you want those comments to be visible. We're also going to have time for dialogue and questions about 10 minutes before the top of the hour. So you can either raise your hand or use the Q&A box to ask your questions. We're going to wrap up the main session at 10 a.m, but then we're very lucky that Carrie has actually given us an extra 30 minutes. So we have Percolator Time so that you can ask her more questions and maybe discuss your own clinical concerns with Carrie as well. So very importantly, registered participants who attend this webinar are going to receive a certificate of attendance. I'm hoping by now this group is very well aware with the PEAS project, but just a reminder that the Pediatric Eating and Swallowing Project is a provincial quality improvement initiative with the purpose of developing clinical pathways to standardise and improve the care of children with pediatric feeding disorder. For this phase of our project, our target population, as you know, has been children in ambulatory care, and we focus most of our resources on outpatient and community care, but these can also be applied or adapted for other settings such as acute care. And I hope all of you are using our website at this time. So PEAS has invited Carrie Owen, an accredited occupational therapist and lactation consultant, to speak about novel ways to manage wait lists using group treatment models and online learning modules. Carrie has been very active in evaluating the program outcomes for all of the work that she does, and like us, she highly values interprofessional teamwork. Carrie is a program designer, facilitator, researcher, lecturer, and author in the field of feeding and related developmental needs of infants, children, and teenagers. She coordinated, developed, and consults to the feeding clinics at the Children's Hospital of Eastern Ontario, and has developed an online learning module for reluctant feeders. Carrie is a clinical researcher and has been the principal investigator for 3 research projects that are focused on interventions for children with PFD, and she's won 2 of CHEO's Gold Ribbon Awards for Innovation and Stewardship. So thank you, Carrie, very much for sharing your knowledge with us today.
I'm very happy to be here. I'm just going to share my screen. Thank you for that lovely introduction. So I feel I have so much to learn from all of you. The work you've done through the PEAS project is very impressive. Your assessment, the information for parents, it's very impressive. Today I'll be focusing on the evaluations that we did for our feeding group. So to analyze the program evaluation results for our CHEO, the Children's Hospital of Eastern Ontario interprofessional feeding group. We're going to talk a lot about how a group approach and a feeding program helps to manage and reduce the extensive wait list that we definitely had for children with feeding challenges. And I'm going to outline the parent perceptions of an interprofessional feeding group treatment model. As was mentioned, I have been a lead in 3 research studies, and 2 were evaluating the effectiveness of the groups, and 1 is the perception of parents in regards to those groups. And then to illustrate the online learning module that I developed for families of children with feeding challenges. What's great is that half hour at the end for those who can stay, because sometimes you have your own objectives, and I'm happy to deal with that. So I just want to mention at CHEO, the feeding groups that I am going to be discussing today are for the children who are considered at time of referral to be medically stable. So they might have had reflux or still have reflux. They may have had some cardiac issues, but those have been resolved. So it's quite a unique population. And our feeding group, our baby group, when we first started was 6 months to 11 months, really almost 1 year. But with the changes in feeding patterns, a lot of parents are starting to feed their babies at 4 months. And then we have the 1 year to 3 year, 11-month group. And then our 4 year to 12 year group, and I'm going into a lot more details about each of these groups. And then with the pandemic, we had to transition to offering those groups virtually. So that was my initial challenge, to do little pilot projects of how best to provide these groups virtually so that we could continue them during the pandemic. So at CHEO in hospital, our team consisted of the occupational therapist, psychologist, dietitian, speech language pathologist, and pediatrician. We also often utilize, excuse me, the rehab assistant, who was very involved in our hands-on sessions. And in hospital, a really important part of the team was our administrative staff. I work at CHEO. I worked running the programs. I worked inpatient. And then I also have a private practice. I'm going to just take a drink of water. I don't know what's happening. And in my private work, I go into homes and work in the community. So in the community, my team would consist of usually a dietitian and myself, the caring physician, and then occasionally there might be a rapid nurse involved or social work, and we would try to coordinate in a similar way. So our group was very much focused on a parent educational model. And before we would even meet the children in the groups, we would meet the parents. We would have received the medical history, the family history. We had a good sense of that child. But in that first session, we would review how feeding is a complex skill. We would listen to what the parents felt were their challenges. We would ask them what their goals were. And then we would even ask them of any of these goals and reviewing these challenges. What are in your a little bit on their own, because they would say, well, as a parent, I can choose the food I offer, or I can choose when to provide the food. We would then at that time have them hopefully they had sent in the feeding screening tool. If not, we gave them some time to complete it. Chantal, who is sitting there, who is a speech language pathologist, she would then exit the room, go through them all, and myself and the psychologist ran the first session. And really it was an introduction to feeding challenges. Depending on the age of the group, we then saw the children at specific time, and we always called it the picnic because that's when the child would attend. They would bring their food. By that time, the parents had identified some goals and some strategies. So they brought the food they were working on. They presented it the way that we had discussed in the group. And what was a great opportunity for us to observe that parent-child caregiver dynamic. We would have, if grandma was a primary person involved in feeding, we would have grandma, we would have babysitters. We really wanted a full team approach. We continued that virtually. We would observe the child and the parent eating. And we continued with some games. So I will go through kind of the details of how we ran the group, but definitely it was setting the stage that the parents felt heard and the parents identified their goals. So when I was initially working at CHEO, my focus was inpatient. And then each of us OTs would pick up outpatient clients as we could. Slowly, I became more of the outpatient OT, and we didn't have a formal feeding team at that time. And our wait list was growing and was enormous. So I felt very frustrated by the wait list. And I started to see in many of the referrals a very common presentation. And so I thought maybe I'll start with just one parent group session. They come in, it'll give them something to work on while they are waiting to be seen. The OT did the initial assessment, and then I would pull in the other professionals needed. So I wanted just to get a sense, was this effective? And I was a busy clinician. I was 0.5 at the hospital. So the whole concept of outcome measures, it had to be easy and simple. So I used a goal attainment scale, and that was something I could easily do. And from that, I started wondering, could an interprofessional team or a multidisciplinary team, group-based program be a more efficient way to providing feeding services as an outpatient basis? The other thing I heard a lot is that I would be working perhaps with a 2-year-old who is drinking gallons of milk. And I knew that had to be reduced before there'd be hunger for solids. But if I'm mentioning this to a family, they'd say, oh, no, my dietitian says he must get this much milk, or my physician says he can't lose weight. And so I felt if we could come together as a team in one room and they could hear the same message from all of us, that consistency of care hopefully would provide with better outcomes for more improved functional feeding. So the initial parent group that we developed and then evaluated were the typically developing children from 1 to 3, again, relatively medically stable. Some of the things we were looking for is just that very fussy at meals, not transitioning well to solid foods, parents reporting gagging, what they perceived as choking, there was vomiting, coughing with the textured food, the refusal of food, the restriction of food, and often, but not always, limited growth velocity. And those were the first group I ran and the children that we saw. Since the beginning, there is now the ARFID's diagnosis. And when I started to look back, the children that I saw had a common denominator, would have fit well into that ARFID diagnosis. And now we have the pediatric feeding disorder, information on that. But definitely the children that I was seeing, many of them would have fit into the pediatric feeding disorder and many under ARFIDs. We did a trial with offering the group with children on the spectrum, and we did it for children. We focused on 2-year-old children. We just did a quick pilot evaluation, very informal. And that program is continuing as well, although due to the pandemic, it was put on hold. So we decided, and again at that time, so we ended up publishing 2012, but we started collecting and running the programs around 2008. There weren't a lot of standardized assessments at that time. So we decided to use a behavioral pediatric feeding assessment scale. And you'll see when I review the results of that, what is interesting is that it looks at parent behavior and parent perception, as well as a child's skill and behavior. And then again, we wanted to use a goal attainment scale. What we liked is we had a section for parent comment, which is what I have found really helpful in the early goal attainment scaling to create the program. And then because we were operating for the first time and we viewed it as an interprofessional team, we wanted to develop a feeding skills scale that reflected OT, psychology, speech, dietitian, physician. And so we created our own. Again, since then, there's a lot out there. The PD Eat is out there. You've got a great feeding assessment. But that's what we did so that we could feel very united and that we felt we were covering the areas the entire team wanted to look at. In our first evaluation of that 1 to 3 group, we did look at the height and weight, and the dietitian would measure. It was interesting because some children were very, very distressed to be weighed. And the other interesting thing we found from doing height and weight is that many of our children were way up in the 85th percentile, primarily because of the amount of drinking and eating all day. So our results showed a significant improvement in the area of looking at the child's skill and the parent's skill for implementing the strategies. So for example, one question is, does my child eat fruit? And they would score how much they ate fruit, if any at all. And then the question is this a problem for you or not? And that's so important when you're trying to get a buy-in from a parent, because if they're feeling fruits are not an important part of their child's diet, then they're not going to work hard at embracing that. Let's focus on fruit. So we looked also at the behavior of the children and the behavior of the parent. So overall, we found that this feeding group was an efficient way to improve feeding skills. The feeding skill scale that we use, this is just an example, and we created it. And the parents, we initially would interview the parents and fill it out. And then we just tweaked it a little bit so the parent could fill it out. And then we would review it. And if we had questions, we would clarify. So that was our feeding skill scale, which we scored. And the end results were that the majority of the children improved on the feeding skill scale. We use that as well as a way to know, should we do some follow-up with some of the children after the group ended. And the follow-up was done by myself as an OT, and I would have 1 or 2 children come back to continue working on the skills. If the skill was very low, I would sometimes do just 1 individual session. If the skills were developing, I might bring 3 families back. The goal attainment scale, the comments were really important for us. One, we had discovered it was an effective intervention, but the feedback from the families was just what I had hoped, is they really appreciated having that consistent message and working with all of us instead of having to seek out a dietitian or seek out psychology, and we were all present. For this group, we did in and we did our picnic, and then we had them implement the strategies for a month at home, and then the parents would come back and give us feedback. The other really important part was that it became a great support, having other parents in the similar situation as themselves, because they often feel alone, that their child is the only one not feeding well, and they would share emails and became a network for each other. So the goal attainment score showed that it was an effective method for improving skills. So what is the next step? What did we feel we should evaluate next? And we had really designed our 4 to 12-year-old group very differently than our 1 to 3-year-old group. So for this one, we only offered 4 sessions with the parents. The first session was parent only, the second and third, and these were weekly sessions, the first 3. The second and third were with parent and child present. And then again, we would give them time to practice and implement the strategies at home, and then they would come back for a 4th session. And we, our session with the children, it was a speech pathologist, Chantal, and myself running that group with a rehab assistant. And then our 4th session was with a psychologist. We offered drop-in follow-up sessions monthly, and that was for the parents to come, because we felt we were not offering follow-up sessions with the children, but we knew they needed encouragement to continue. What was very surprising to us, and we changed the time of that group to accommodate parents the best we could. I think in a total of 35 participants, we had 4 parents come to a few monthly sessions. So that was very interesting for us. The parent feedback was if we were going to have the children back, they would come. So this shows you how we would set up the group for the 4 to 12-year-old. For the first session, I'm in the background at the table with the parents, because the children were coming in, especially the younger children. They weren't ready for their parent to leave the room yet. But as most of you know, children function so very differently with people other than their parents. So we did want weight. We would start the group with the children. We would, our first session with them was always making a very simple pizza. And we had a lot of fun utensils like scissors and pastry brushes and skewers. And we would have them paint the tomato paste on. Now, what we told the children right away, because they came in with wide-eyed, looking so nervous, we'd say, you're going to make pizza for your parent, and let's hide some fun little things in there so that you can surprise them and see if they figure it out. And when they learned that the focus wasn't on them, are you going to eat this pizza? We want you to eat this pizza. They really did eagerly participate, and we tried our very best for a hands-off approach. Now that we've switched it over to virtual, we do have them do a similar thing with their parent or caregiver in the home. And then in the back, I would be going over their feeding screening tool, clarifying any questions, and then review the strategies. Because in the first session, when they came without their child, we do a PowerPoint, and then we have them identify what is their goal or 2 goals for the week until we see them again. We tell the children the second session for them, the parent and myself are just going down the hallway. And at that point, we would be in another room so we could discuss more actively what the children were doing. In that second session, when the parents weren't around, we used a lot of fun games, because you know you have to motivate that child who is so apprehensive, possibly afraid of trying new foods. There has to be motivation. And so in the group, we would utilize whatever foods we had that we were using for the cooking experience. So for instance, there might be a mushroom, there could be a red pepper, there'd be cheese. And we would teach them what the game was, and it was always appropriate for their age and developmental level. And then we would model that you could not have your turn, taking your turn involved maybe kissing the mushroom or tapping the pepper on your nose or holding it in your mouth with a count of 2 or breaking it in half with your teeth. And because they were a group and they were keen to play, what we wanted them to do with that food. And the parent wasn't present, but we would videotape the session so that when the parents came back after their month away, we would show them that video of how well they did trying the food, because we'd often say, oh, so-and-so, he actually took 2 little bites and swallows of a mushroom. Their parent would be like, oh, I can't believe that's true. And this activity is one that I teach the parents a lot at a non-meal time to motivate them to try the food. So it's a very hands-on group for them. The measures we used then was, again, the behavioral pediatric feeding assessment scale. We used our CHEO feeding skill scale again. And we took a baseline and then we reassessed at the 4th session. And we saw then improvement in function. We liked that the parents were less frustrated or anxious. That they stopped making and serving them something else if they didn't eat some of their food. And we always stress to have something that they're comfortable with on the plate, that hit and miss food they were eating 3 weeks ago, and then the new food. So we were able to see improvement in the parental perception. And then in the children's feeding behavior, this is an example of us looking at the baseline results and then looking at 6 months down the road. So we did mail out for the assessment because the CRIST is an assessment parents fill out. We were pretty successful at getting the results back in, but we also had to do a couple of phone calls for some parents. But we were curious what happens over that 6-month period, especially when the parents weren't coming to the drop-in sessions where we could touch base with them. So on average, there was a increase in eating more fruits and looking at the parents' confidence with the fact that they felt their child was eating enough, and there was a decrease in what parents perceived as choking and gagging at meal times, the vomiting, the whining, the crying. And so we felt that the parents were in a better place. So when we first meet them, often they just really quantity, and we gave them permission to smile, even though inside you're not feeling like smiling, and being accepting what the child was eating. We will always stress that during this time of change, that it's extremely hard for children to accept change and for parents to make changes. So we stress that in that period of time, there's weight maintenance and often weight loss. But we were well connected to the physicians and the community physicians. And so we were able to say, your physician referred you to the program. They are aware there could be weight loss. What we would say in the 1 to 3-year-old group is that within 6 months, you're going to start feeling like these strategies are really going to work. But we stress that it took time, and we would always say when we'd have the parent identify what strategy they were going to work on, sometimes it was just not showing frustration and anger. Sometimes it would be reducing the amount of milk. Sometimes they'd say, oh, I'm going to reduce the grazing throughout the day. And we would always say, you must start with something that no matter what your child's reaction is, you will maintain and continue to do. And so I would say you might find you can only start on a weekend, or you might find you can only start some of these strategies with snack. And because I want you to know that you're not going to slide back, you're not going to go back into your ways, the progress is better off that we do small, tiny steps rather than take everything on at once. In that 4 to 12-year-old group, I would say a year. I would say to them, you're going to see potential changes in about 8 to 10 months, but for what you're really hoping to see, it can take up to a year. And I would also tell them, especially for the 1-year-old group or my baby group, when weight is such a focus for them, I would say it's up to the professionals to worry about weight, and you as a parent want to implement good functional feeding strategies. I always say that child's going to be eating for the next 80 years of their life, so we really have to give them that skill base. And I would stress that learning to eat is a skill a child has to develop.
Carrie, sorry, this is Justine. Sorry to interrupt, but you've been cutting out a little bit, so it may be the Wi-Fi or internet that you're on. I'm wondering if you're able to turn your video off temporarily, because we're missing some of the wonderful things that you're telling us.
Yeah, Justine, I can hear you. I'm just messaging with Carrie right now. Sorry,
Yeah.
everyone, just give us a minute here.
Yeah, apologies, everyone. It's probably the internet, the joys of virtual life, but we'll get this sorted briefly.
And in the meantime, if there are some questions you want to start typing into the Q&A, you're welcome to. I'm just going to answer this call. It's Carrie.
I will unmute and I'll go back. Okay, I'm back.
Perfect. And maybe go back to that baseline versus 6 months. Just like
Right there. Okay, thank you. Okay, I apologize for that. We lost connection. So I understand this is where you last heard me. So on average, there was what we were very pleased with was the parents felt confident that the child was eating enough. And for example, that they would eat fruit. And then another example of what we were seeing was a decrease in the choking or gagging. And when I say choking, it's the parent's perception of choking. Usually it was more retching from the texture, a reduction in the vomit, the whining, the crying at feeding time. We really liked hearing that the parent wasn't rushing off to make anything new for them, and that they were not feeling that their child's eating pattern was hurting their general health. What I talked about was that I would let parents know that in the 1 to 3 age group, I would say that in 6 months, you're going to start seeing improvement, and you'll start hitting all your goals. And with that 4 to 12-year-old group, I would say it can take 8 to 10 months before you're going to really start seeing change. So it gave them a little bit of freedom to play with some of these strategies, knowing that they weren't going to see success right away. As well, I stress that during this time of change, which is hard for the child and hard for the parent, there could be a maintenance of a plateau of weight or a decrease of weight. But I emphasize that we were in close connection, communication with the referring physicians, and they understood this, and that we would expect to see some weight gain again around that 6-month period of time. And stress that for the next 80 years, your child could be, will be eating. And so developing those functional feeding skills are so important. And by doing that, we would not be encouraging that the child drank as much milk or had yogurt 5 times a day or only had mac and cheese at dinner, so that they would understand this would take time. We also stress for them to identify the one strategy that they would work on no matter what their child would do. So if their child suddenly stopped eating their favorite food or got a little more frustrated at the table, they would stick with it. So sometimes we'd say, just use this and implement it on the weekend or at snack time. So we discovered and we knew from those 2 evaluations that a group approach, and we would often have 8 families in a group, resulted in improvement with functional feeding. But I wondered how the parents felt about that group approach versus the individual. We had gotten some feedback saying they liked having all the professionals together in one room. So we decided to evaluate the parent perception. So we knew that interprofessional or multidisciplinary treatment was supported in the literature. The parents' perception of parent training, interprofessional approach wasn't well developed. And we wanted to look at the cost effectiveness of these groups because we wanted the groups to be continued. So we wanted the buy-in from administration to continue the groups. Our hypothesis was that the parents would be more satisfied with the group. We would have a reduction in follow-up visits for the children in the group, and that the skill development in the individual treatment and in the group would be equal. And we wondered if the attendance would be improved in the group therapy as the times were structured and booked in advance. So the individual OT treatment is very traditional. The family would come in with the child, the OT would do the assessment and then set up follow-up appointments as required based on the progression of the child. The interprofessional feeding group, we offered 5 sessions, again with 4 of the sessions being the parents only or caregivers only. And the 4th session, as you can see, was very much interaction with the food, cooking, drawing, coloring with the food, and then having a meal. We always offered this around a lunchtime. We had 40 participants. The group assignment was simple randomization. Again, we used the CHEO feeding skill assessment, and this time we looked at the measure of process of care, the MPOC 20, to measure parental satisfaction and perception of the care. So as we anticipating, the feeding skills progressed and were adequate in both groups. So it was a functional approach for the group as it was the individual treatment to advance those feeding skills. We did discover, and in this assessment was done with 1 to 3-year-old children, and we found the group intervention approach required fewer follow-up visits than the individual treatment. So in the group, we would see the children once and then require 2 follow-up visits versus the individual session and 6 visits. Our wait times, which is what was the driving force at the beginning, was lowered by 71% in the group. And the overall satisfaction of the parents was quite high across all 5 constructs of the assessment tool. But it was interesting, overall, their satisfaction was higher in the individual treatment. So the group intervention, The satisfaction was statistically significant, but it was higher for the individual. And I have a good idea as to why. So when you look at the individual in the dark blue and the group in the light blue, there was improvement in all areas. And they look at enabling partnership, providing general information, providing specific information about the group, coordinated and comprehensive care, and was it respectful and supportive. So the parents in both the group and the individual were most satisfied in the two categories: the coordinated and comprehensive care, which makes sense, particularly in the group because you have the team, and the respectful and supportive care. Parents were satisfied with the interprofessional group intervention for the children. And what we found was the group intervention increased access to care, because in that environment, they would have access to all the different disciplines in a very efficient, functional time. Just going back, the providing specific information about the child, and I think for any of you who've worked particularly in the community or in the home. And I know when I was providing the feeding assessment and feeding strategies, the parents would ask me about toilet training, or the child was anxious about going to school, or the child was having sleep issues. And in that individual session, I would provide resources or some guidance in those areas. Within the feeding group, the focus was primarily on feeding. So it made sense that the parents really liked that individual attention to get more about different areas of development. They'd ask about play or fine motor. But overall, the parents were satisfied with the group approach. To manage the wait list as well, which news of these feeding groups grew throughout the community, and the referrals were pouring in. So we decided to create a feeding module, which was interactive for the parents. And our purpose was, again, while they were waiting, they would have a lot of the information that we touch on in the group. And we were hoping that some of the families just needed to hear some of these strategies, implement them, and then realize, you know, that's all we had to do. We don't really need to come to the full group. And it was a really nice way to get the parents learning about feeding ahead of the session. And we would often have parents say, oh, I watched the module and I've implemented these two strategies and they really work, but I'm having a hard time with this one. In order for the families to be put on the list for booking, we had to see that they had watched the module. So in this one, if they click on family, then a number of screens pop up talking about how family interaction, how family history can impact on feeding. And then these were all the areas that were reviewed. So they would click on each one and there'd be 3 or 4 screens that again they would click on. So one, if they clicked on have mealtime with family together, one might be click on eating alone, one might be click on eating as a family, and the advantages would be reviewed. So it was narrated by myself but it was also interactive in that the parents could pick and choose what areas they wanted to look at one time, if they just wanted to do it in small sections. We had just started to evaluate this before the pandemic, and that put a little hold on that, but I know they're going to be starting that up again. So we got a lot of good feedback. And as I said, some parents were like, I've implemented some of these strategies and I'm good for now. And I think I've made it. I know I rushed through the end because I'm supposed to be open for discussion. And again, I apologize for that disconnection.
Carrie, not at all. Thank you so much. You've had such positive responses in the chat. I'm hoping you'll have a chance to see all the wonderful things people have been saying about your presentation, and people who are saying they want to collaborate with you, Carrie.
Oh, lovely, lovely.
Okay, so thank you so much. We do have the 10 minutes, so you did get us right on time for some questions now, and then I'm hoping many of you, especially those who would like to talk about collaborating, have the chance to stay for the percolator. So I'm going to start with a question that was actually posted in the chat because it's a question I have for Carrie. So are the timelines that you were giving families for anticipated changes to be impactful and occur based on your experience, or do you have some references for that you can share with us?
No, I don't have references. It was on our list of something to evaluate. So we just roughly would make notes on when parents were starting to either in that 1 to 3 group say, oh, we don't need you anymore, or based on our clinical experience. But no, there's nothing documented, nothing in the literature. And as I was trying to say, it really depended on how committed the parents were to implementing the strategies.
Okay.
So if they did it, and it would depend too if the families were if the parents were divorced and there's 2 different homes and they had different methods and which strategies, but we have clinically found that 6 months is pretty fair. When we're dealing with our 9 and 10-year-olds, it's definitely a year.
Yeah,
which I know is discouraging.
I totally agree. I think that's one of the biggest challenges for families is it takes so much time, right? Yeah. And they feel frustrated. The incremental changes seem so small to them, and I'm sure as therapists, many of you are so excited about those tiny incremental changes, but for the families, they want so much more. So that kind of preparing them to understand that is so critical. So a couple of questions from Courtney and from Sonia. Do you have non-English speakers in your groups, or how do you address that?
So that's a great question. So initially, it was English only. That's my limitation because I only spoke English. But then as we expanded and we had more professionals, we would offer it in French and English. We had tried a few times to bring an interpreter into the group, and we didn't find that we got as much from the parents sharing that way, but we did trial that. When I was in the home, we always had access to an interpreter, and I found the interpreter in the home, I could get a better sense of what that parent was feeling. So that is one area that we were slowly expanding, but it's bilingual now, French and English at this point.
Very interesting. And then there are a couple of people who've asked in the chat, are your virtual sessions available to be shared with families or people they're working with? Yeah, a couple of questions about that. The interactive parent module, are they available?
So right. Well, it's interesting you asked that because right now they're not. But I have we have a real change happening in the Ottawa area. So the feeding providers in more of the rural area are being administered now by CHEO. And so I am providing virtual learning sessions for them. And that I could discuss that with the manager to see if that could be made available, because that's the idea. There's a lot of OT, speech pathologists, dietitians now out in the community having to serve even more of the babies going home on the feeding tubes, and the challenges with transitioning from breast or bottle to solids. So I am developing virtual learning sessions for that. But as to the group virtual sessions being available, that wouldn't be up to me, but I can bring it back and ask.
And the modules, have you made them available, Carrie?
So the modules, before the pandemic, we were just in the process of getting them copyright and getting them ready to go. It stalled out with the lawyers, and then the pandemic hit. So we're back to trying to make that available, because why recreate them?
Yeah, well, we would definitely like to keep in touch with you, but I will say that AHS is also committed to putting together a virtual series as well through the PEAS project. So it may be that we might consult with you about that. That would be wonderful. Thank you. Okay, so another question. Were the sessions offered during the day during the school year? Because that's often a challenge for families.
So yes, they were. And we did offer them, I think not the baby group, but the 1 to 12-year-old group. We'd start at 11, so that parents who were working, we said you can eat your lunch and take a little bit of time off. The hand and language program, through the speech language pathologist, offered weekends, offered evenings. And what they were hearing is parents, their kids were so involved in extracurricular activities, they preferred the daytime. So we stayed with the daytime, and our groups were full. Occasionally they may have come up and ready to join a group, and because of things going on, they'd say, I have to wait for the next group. But we didn't have issues with that timing. Okay. Sometimes both parents couldn't be there. And even back then, we would do a little bit of virtual with a parent who couldn't be there. And our follow-up session with parents, we were just transitioning to virtual follow-up sessions, so parents could sit in their office at work when the pandemic hit.
Okay, so there is another question from Courtney. Did you include children in your groups with autism spectrum disorder, and how did you adjust for them?
Oh, no, we didn't. So really, it's that medically stable child. It's the child that did not have developmentally delays or were on the spectrum. But as I briefly mentioned, and I might have been in and out at that time, we did a pilot, very, very limited pilot study. We ran in a similar format, a group for 2-year-olds who are on the spectrum. And what we learned from that is you need way more staff and you need a room without cupboards and drawers, and our whole makeup wasn't great. But the parental feedback was good. They liked some of the individual sessions along with the group sessions. So I know those programs were being started up again just before the pandemic, and they're looking at definitely providing them now. So we had different stations. They were play stations with food where the child could eat the food. And then we did the parent learning and then the parent follow-up. And you certainly couldn't have 8 children in that group. So
Okay.
we did do it. Yeah.
Okay. So I think we've got time for one more question, and then I'm going to ask those of you who posted questions, thank you so much that you have the opportunity to move up to stay if you can and ask during the percolator. But Christina asked, were there other areas identified within the children during the process and of concern, and were those services attained by other OTs, SLPs, or behavioural services?
That's a great question. So in our 1 to 3-year-old group, we had the psychologist who would provide at times individual sessions for parents that might have identified they had high anxiety themselves, or they would identify their child had high anxiety and was having issues at school. So the psychologist would book separate sessions with them. Often when we saw the 1.5-year-olds, we would see that there were developmental issues we were concerned about, or we felt they were on the spectrum. So then we would refer to the other OTs. When we started, the Children's Hospital and the Ottawa Children's Treatment Center were completely different and funded by different ministers. Provincial programs. And so we would have to refer to them, and the wait list for them was enormous. Now it's an integrated program between the two, so it should run on an easier basis. Our older group, we didn't have access to a dietitian as part of our regular group, but how the department had set it up was that if we red flagged a child who needed a dietitian, then that referral, they would step in to help them. Sometimes we would be seeing a child in our feeding group who is also already being seen by the OT for developmental or coordinated issues. So we were able to coordinate that way. The other thing that started happening with our older group is that some of our clients were being seen by the chronic pain team. So then we had access to them. In the community, when I'm doing my sessions and the dietitian and I will meet together, or the rapid nurse and myself will meet together, it's not as cohesive. And the referrals can take longer because sometimes I want a physio involved. So hospital-based is definitely easier to page and pull people in than in the community. But I find in the community, because we don't have access, we're so happy to work together as
that's nice. It's lovely. All right, Carrie, thank you so much for your presentation today. It was incredibly well received, and I think you're going to be busy for the next 15-20 minutes during the percolator. For those of you that can't stay and ask Carrie your burning questions, I'm sure Vanessa would be happy if you emailed her, and we can always ask Carrie, I'm sure, if there's some help she can provide afterwards to answer some of those questions. So for now, we're going to wrap up and move on to the percolator. I would just encourage you all to consider subscribing to our community of practice, which is available to all healthcare providers, so we can build our community and capture the spirit and harness the power of collaboration, so that we can provide the interdisciplinary care required for our pediatric feeding disorder patients. Carrie, if you wouldn't mind stopping sharing, we have a couple of final slides. Okay. Thank you. And actually, of course, in our community of practice is also where you will find this presentation posted, so that if you know of any of your colleagues who you think would value this presentation who weren't able to present today, please remind them that it will be posted there for them. Please share your feedback with us. The link was posted in the comments, but also is here for you as well. Your feedback is very valuable and will really help us guide some future webinars. And then the 30-minute Percolator. I'm not sure if Carrie has the whole 30 minutes, but we'll see. You do. Oh, thank you, Carrie, so much. It begins now, and thank you very much again. I can't stay for the Percolator, but I'm so privileged to have heard you speak again, Carrie. I heard you at Feeding Matters as well. Thank you, everyone, for your participation today. Please feel free to contact Pease if you have any questions or suggestions. Bye-bye from me, and good luck for the rest of you for the morning. Bye-bye.
Bye.
Wonderful. Thanks so much. I think what we'll do, Carrie, is pick up where we left off. And there are a number of questions still in our chat window. So I'm just going to turn it over to Beverly if she doesn't mind helping to moderate this portion of the session. And again, for everyone who's on the line, please feel free to use the chat window for comments, the Q&A for your questions. And if you would like to just speak out loud, feel free to raise your hand and we'll take you off of mute.
There's one I would love to address right away. Sorry. Because it was something I did want to mention. So there's a question about, did I believe having a pharmacist as part of the interprofessional team would help to improve care of this patient group? What I find Ottawa has been very slow to introduce is an appetite stimulant. Our one physician from the feeding disorders clinic was starting to use it. Montreal is using an appetite stimulant in children, and that is something I would like to see more access to and information. So it would be great to have at least access to a pharmacist who would come in and discuss that with families. And many of the community physicians, when I have recommended it, will call me to ask me about it and its use. So I usually send articles on it. My own experience is that there's still a lot that doesn't seem to be known about it. If they take a break, if they use it constantly, I would say I've seen some great success with it. And I've also seen where it hasn't made a lot of change. So yes, that was a great question. And now I will pass it over.
This is Beverly. Thanks again, Carrie. What a great presentation. We still have lots of questions in the Q&A, and we remind those who are still able to be with us for this percolator to please post your questions to the question and answer. So we have a question from Kate. Kate's working with a few preschool-age children who have autism spectrum disorder who only drink fluids from a baby bottle, and parents are reluctant to get rid of the bottle. Any ideas? Carrie's internet has been unstable. Carrie, can you hear us?
Oh, we must have lost her again.
Carrie's coming to us from rural Ontario, just outside of Ottawa. So although it's not a snowy day, oh, Carrie, we got you back.
Oh, it is snowing here and windy. So I think that's exactly what's happening to me, but I'm back. Sorry.
Oh, we're glad you're back. Carrie, we have a question.
Oh, no, I lost you again.
From a clinic. We have lots of questions. Here's a question from a clinician who's working with a few preschool-age children who have autism spectrum disorder who only drink fluids from a baby bottle, and parents are reluctant to get rid of the bottle. Do you have any ideas for us?
Well, yes, I've seen that a lot. So, you know, I always say it's got to be fun and it's got to be motivating. So I've done, you know, the little stepping stones with the teddy bear, squeezable, or often they like the parents' little water bottles. And then I look at if there is any puree that they happen to like at all. And then I rim whatever straw or little cup we're introducing. If they like chocolate pudding, if they like applesauce, if they like ice cream. And so I'll start rimming the straw or rimming the little water bottle top or the yogurt tops. And then I really look at, can we start weaning down some of what they are drinking? So it's looking at what's a fun alternative and looking at adding taste. Sometimes if I have a child who happens to love ice cream, which I don't always do, then I'll put a little easy peasy cup and it'll be 99% ice cream with 1% milk, and I'll rim it with the ice cream just to get them taking something that they like, almost making it a smoothie and introducing other fun cups, having them decorate the cup. But it is extremely challenging. And I would look at how much. Usually when they're taking the bottle, they're drinking too much. So that would be the other thing I'd be looking at.
Thanks so much, Carrie. That's so many pragmatic ideas for us. We have a question about how you facilitated food play and interaction in your virtual group.
So the food play for the virtual group, we would start very simple. I would have them have access to either a little pita or a rice cake. I'd get them to get a paintbrush or a pastry brush, and I would do it, and the parents would facilitate the child doing it in making the little pizzas, or I use a lot of fun skewers, and I would have the children make little kebabs, or I would have the parents preset the kebabs so that the food the child was most comfortable is at the end. So they have to pull everything off the kebab skewer to get to what they want. I also have a Pinterest site where I have sensory food activities. So I might have them have a little bin with cooked noodles, and I'd have them pick up little things from the dollar store that they knew their child would like and bring it on. We'd all have our bin and we'd go searching to see what were some of the fun things that the parents had hidden. So I would do it and they do it. I even virtually will do that game that you saw in the group. So I will use snakes and ladders. There's a really great little game through Zoom, and it's snakes and ladders, but with food. And then we'd all have to kiss our strawberry or the mushroom before they took their turn. And it's worked very well.
It all sounds so collaborative, Carrie.
It is quite interesting how I think because of the pandemic, children are really comfortable with the screen now and interactions with the screen. So it has worked.
Thanks so much for that. Some of our participants are interested in the CHEO feeding skills measure that your team created. Is your team at a place or in a position to share that?
I would imagine they are. I will talk to the team and just make sure, but I can't see why not. When we were creating it, we looked at the Montreal Children's Hospital feeding scale, which is very similar. It's a good one to look at too. but I will talk to the team, and I can't see why we wouldn't share it, because it was just really unique to our particular team. So it might give you just a guideline.
Thanks so much, Carrie, for that. And for those in Alberta, we can post, if Carrie's team is able to make that available to PEAS, we can post it on the community of practice.
Good. Yeah.
Thanks. And with respect to your groups, were siblings able to attend?
So it always depends. If it was during RSV season or flu season, no, they were not allowed to attend. But often we did have siblings come. Sometimes it was because there was no sitter, different circumstances, but we would have siblings attend. Or if often we would learn that the other sibling had as many challenges, and the parents said, would it be okay if we just brought them in? And we would say they can come in, they can observe. It'd be interesting to see the dynamics, but that would be a new referral. So we just had to be careful that, yeah, in just 1.5 hour session, we're not going to have a full assessment. But we had siblings, and as I mentioned, grandmas, nannies, aunts. We welcomed a lot into our group.
And did you find that it changed the dynamic of the interaction?
We didn't feel it was something that we required to in order to see that child make efficient gains, but more we wanted, if that was the only way to get the family together, then we would welcome them. But we, you know, our room, if you have 8 families, 2 parents, 2 siblings, and the child, it got a little crowded. Now, that's one advantage of the virtual sessions, is that often if it's at a mealtime, you do see the siblings there. And you see that dynamic between the siblings. But I have found that by the time you've had 3 or 4 sessions with that family, you've got a pretty good idea of what that other sibling's doing, because sometimes the other sibling will have ADHD and won't sit at the table. And so they say, how am I going to get my child sitting at the table if her older brother doesn't sit at the table? So you've gotten a pretty good picture of the whole family dynamics, but it's not at a point where we would feel that that was a requirement and we would open it up to siblings.
Thanks, Carrie. Did your team ever create sessions for children who were older than 10?
Well, our evaluation was for, we did run groups from kind of 12 to 15 years of age, and the dynamic's very different there. So we would always start with a parent educational model, because if we had enough families, because we felt they really needed to understand that feeding is a challenging skill for everyone to develop, and that the emotions behind trying new foods and the importance of not grazing. And then when we met with the older teen, we would have their input on what food do you wish you would like to eat. And that's where we would start. And then we would just change some of the tasks, like for some of the older ones who were interested in trying a hamburger, but didn't really want to try a hamburger, would only eat one kind of hamburger. We'd say, okay, identify 4 fast food places. And we create a little evaluation tool, and we'd have them go to the 5 drive-throughs or eat-ins, whatever they wanted to do, and bring that feedback to us, and they had a lot of fun doing that. And we do like the Pepsi Cola challenge. So our activities changed, but it was based very much on that child identifying what food they were somewhat interested in trying. Because again, for that age group, we were only allotted 4 sessions just because of staffing. And that's a really tough age to work with, but we did have buy-in. And what was lovely too with some of the older ones is they could verbalize their fear of trying new food, and they would empathize with the other team.
Thanks so much for describing how you would change the strategies. Here's a comment about relaxation before the group session was, would you have ever considered pairing, and I apologize if I don't pronounce this correctly, Wilsonozolin session?
Snoozolin sessions.
Snoozolin session.
So definitely when we were doing our work with our one group with the children on the spectrum, that was definitely an activity we would do before. If we had a group at the table and they were just so restless, sometimes we do a little marching around the table to sit them down. Our timing was very limited, so we really wanted to look at those oral motor skills, the behavior around feeding, but we would often have resources and make recommendations that families do some preparation as well. We talked a lot about the transitions from doing their favorite activity or game to then having to quickly transition to the table to the task of eating, which they did not enjoy. We talked a lot about looking at a way to transition smoother to the table. And so sometimes that would include a bear hug or washing their hands with a particular scented soap. So we would talk more in terms of the transition from highly motivated activity the child was participating in to the meal they were not really wanting to be a part of.
Mm-hmm. Thanks, Carrie. Our next question encompasses the feeding skills domain as one of the 4 domains in the pediatric feeding disorder framework, and that is oral motor or oral sensory motor skills. Were they addressed in your groups or with your clients?
Yes. So when we had what we call the picnic, the speech language pathologist and myself would, and that's why we always said, bring a food that the child can eat, because you can learn a lot about their oral motor skills from their eating. So we definitely assessed their oral motor skills. And if we felt there was significant issues, then if they were in the 1 to 3-year-old group, we would see them for follow-up sessions for that. Between the speech pathologist and myself, we would determine who was best to see them for that follow-up. So there were a few children at times for us to really see what was going on with their oral motor skills. We did have access to some quiet rooms, more play rooms, where one of us would move them over to a quiet room, get them a little calmer so that we could thoroughly assess that.
Thanks so much. This is about the psychologist's involvement in your interprofessional and your group sessions. What was the extent of the psychologist's involvement in your groups?
So with our 1 to 3, which is now 1 to 4 group, our psychologist was actively involved. So in our first session, it was the OT and the psychologist, and we would introduce strategies. And the psychologist talked a lot about focusing on the positive behavior and letting families understand that, as many families only focused on what wasn't eaten, or all that table talk about, well, you liked it yesterday, why don't you like it today? She really emphasized the importance of focusing on the positive. I like the way you sat for 3 minutes at the table and joined us. I like the way you touched the carrot. She would talk about the stress and how it was a highly stressful event, mealtimes for parents, and that it was something they had to do 3 to 6 times a day, and how to manage their parental stress, how to manage the interaction. With the older group, she would come in at the end, at the final session, and review some of that information. Because we considered ourselves an interprofessional team, and she was pulled in so many directions, she would have us, for the older group, share her slides, review the strategies that she wanted implemented, and then she would be there to clarify and go into more detail of that. For the younger children, she would provide some individual sessions. For the older children, she didn't have the access to a lot of that individualized sessions that definitely the family and child would benefit from, but we would refer them to different community resources if she felt they needed more. We would love more of everybody and more time of everybody, but we had to work within our constraints.
I think that's a truism across across all sites and services, isn't it?
Yeah, it is.
Carrie, it looks like we're getting close to our 10:30 mark. And respecting your time and understanding that our attendees might have to sign off, I'm wondering, would you be willing to write out some responses to the remaining questions so we could post it to our PEAS website?
Absolutely. And I just saw one. Yes, it's a cyproheptadine that we use the most, that I've seen used the most. And yes, send me or email me the questions, and I'm happy to answer them.
Thank you so much. Thank you, Carrie, for such an engaging presentation and spending an extra 30 minutes with us to dive deep into our clinical questions. And thanks for everybody who are participated today. And your engaging and thoughtful questions.
Well, thank you for having me. And I always enjoy the discussion and questions the most. So I appreciated that we had time to do that.
Thanks so much.
Thanks, Carrie.
Have we lost Carrie?
Oh, I think we did. She's good. I guess she's, yep, all good. I'll send her those remaining questions though. I'm just gonna take a screenshot. Thanks for taking over the reins there, Bev.
Oh, my pleasure. What a great session today.
So good. Yeah, right on the mark. Okay, well, I'll just stay and wrap up the recording, but thanks for taking over there, Bev. I appreciate it.
Thanks. Okay, shall I sign off?
Okay.